So today I am very pleased to be able to share with you sort of a different aspect of patient engagement and decision making on a maybe different level in terms of advocacy work. So I'm going to talk a little bit about the roles of patient advocates and give you a couple of examples to kind of see what happens when an organization is really committed to evidence-based healthcare, sort of the good, bad, and the ugly that attend to that, and then identify, some of the consequences of that and how we work with the public, with the media, and the health provider community on these kinds of issues. And I think they also contribute to shared decision-making in the clinic. So the National Breast Cancer Coalition was organized and got started about 21 years ago, and it is a coalition of hundreds of organizations and thousands of individuals who got together to understand, with an understanding that to end breast cancer, which was our mission back in 1991 and still is, that we really have to look at that kind of putting federal funding towards research, which at the time there was very, very little, hard to believe today, but there was $90 million in total that was allocated to research in breast cancer at that time, that this was going to be a political issue, making the ending of breast cancer a national priority, political issue, and to this day we work on all those fronts: research, access, and influence. There's been a lot of work done, and I don't think anyone is unaware of breast cancer these days, and no one's afraid to say those two words, which really was the case 20, 30 years ago. And I would point to a couple of key accomplishments that have happened in the field, and also some that we can point to in terms of what the National Breast Cancer Coalition has brought to the conversation. Understanding that educated consumers have a central role in working towards this mission was something that the National Breast Cancer Coalition really, in many ways, pioneered. And I'll talk about that a little bit later. We helped to develop some new mechanisms of research, and I think one of the best examples is the Department of Defense Breast Cancer Research Program, which many of you may know about. But it really was a situation where we helped to define new mechanisms, such as innovator grants and new investigator grants, centers of excellence, which were multidisciplinary centers that got funding for work that was not being done at the NIH level. And the other part that was so important was that advocates became integrally involved and interrelated in every aspect of the DoD program, and this is true to this day. So the integration panel, the peer review panel, the programmatic review panel, the vision setting panel are all co-chaired by an advocate and a scientist. And the peer review program includes trained and educated advocates, the vast majority of them trained through the program that I run, Project Lead. We also were involved in legislation that ushered in a new system of health care for the uninsured and underinsured with the CDC Breast and Cervical Cancer Treatment Program, which was the companion piece that was missing in the CDC Breast and Cervical Cancer Screening Program, which did not have a treatment component to it, and NBCC felt it was unethical, to say the least, to diagnose uninsured women and then tell them there's no treatment funding for that. So that took 6 years of work through Congress, and it is a program that the states administer through Medicaid and state programs in every state of the country. And so we were involved on many levels, and we can point to some progress. We can also say that in terms of the vast investment in research in breast cancer, and over $3 billion alone from the DoD program in the last 18 years, and that isn't including the NIH funding and all the private money and drug experimentations and so on. So a huge investment in breast cancer research over the years, and we can say that we learned a great deal. We know that breast cancer is not one disease. It's multiple diseases. We know that has implications for targeted therapies and for early detection and for all sorts of things. We know that All in all, since 1975, we've seen a reduction in mortality of about less than 30%, and most of that is attributable to better treatment. Some smaller percentage of that is attributable to early detection screening. And we know that there's been a significant increase in funding for research and a central role for advocates in this world. So we can say that there's been some progress. But in looking back over these 20 years, in 2010, NBCC, we composed a status report, put together a status report of where we were with breast cancer and where we were in terms of our mission. And we felt that it was clearly not enough, not nearly enough. And we had launched our Breast Cancer Deadline 2020 initiative, which we hope will be our last initiative, to really put in place a plan by the end of the decade to figure out and to know how we're going to end breast cancer, to reinvigorate the science, to reinvigorate the sense of urgency, to look at very different ways of collaborating, to bring together this enormous investment in research and start pulling it together in a very focused way, a kind of an Apollo project, the end of polio, all of the kinds of large or audacious projects that we know about that can happen, and put that and apply that to breast cancer. Our focus is on prevention, on two areas that actually have not gotten very much attention, and that's primary prevention and prevention of metastasis. And we know that over 90% of women die of metastatic disease, when cancer leaves the breast, goes to other organs, and yet there's very little research going on in metastasis. So that's where we are pulling together the research. And if anyone's interested to know how we're doing this and with whom we're doing it and so on, I'm happy to talk to you about this. We're also working on a vaccine, a prophylactic vaccine, with a group of scientists from around the country. So, but the organization has always lived according to these principles, that it's a grassroots, patient-centered perspective, that educated advocates really need to be at all the decision tables where decisions are being made about breast cancer. So we talk about shared decision-making in a little bit different terms than what we've been talking about in the last day and a half, but it's kind of the same concept, is sharing, influencing, really making our voices heard. We have an abiding reliance on evidence, and evidence that comes as much as possible from clinical trials, and clinical trials that are significant, meaningful, well-designed, which many of them, to our dismay, are not. And we've also had a very, very large investment in care about quality care for all. And our project for the last 20 years, Measuring What Matters, has to do with really kind of helping to define what is quality care in breast cancer and how do we measure whether we've had it or not. But the key to a lot of our work is really in educating advocates, and we have a very, very large investment in that kind of work. We created a program called Project Lead in 1995. That curriculum and that program was put together by advocates in concert with scientists and researchers, and particularly with people who have a tremendous expertise in adult learning. And the programs are really built around the concepts and principles of adult learning, and especially adult learning of very complex information. So we select the participants. They have to apply. There's an application process. We always have very many more applicants than we have spots. And we are very careful and very, we've got a lot of expectation for our faculty. And the faculty have to, of course, be brilliant in their content areas, but most of all, they have to be brilliant teachers, and teachers of adults, of adult complex learning. And I can just say that you can see how choosy and picky and what high standards we have when I tell you that both Karen and Dale have been teachers in our quality care program. So we have trained over 2,000 advocates in the last whenever it is, so 1995. And we have also an array of courses. So we have an introductory course that's 2.5 days long. We have an institute that's 6 days long. We have a clinical trials program that's an advanced course. And we have the quality care program and an international program. So we've been running this program in various countries over the last years as well. And we really are, it's very demanding. We have continuing education. This is our Lead Grads Online, our virtual community where we talk about new articles and papers and stuff that we see in the media, controversies, new data that's coming out. We also have other kinds of continuing education programs, advanced topics. We have an advanced topic, for example, at the San Antonio Breast Cancer Symposium and at other scientific meetings as well. So what do our Project Lead graduates do? I've mentioned that they review research grants, but many of them really translate, they function as translators for the research results in their communities, whether it's research that comes out in the media, because I'm sure you all know that we've already cured breast cancer. We cure it every other day practically in the media, and people have to really explain this to people, to the community, that curing breast cancer in 6 mice is, we're not that close to curing breast cancer in women or men. People sit on IRBs, they sit on policy setting committees, they work on comparative effectiveness research, they work on clinical trials, on protocol committees and DSMBs, and above all, they support evidence-based healthcare in whatever areas they work in, whether they're peer educators or patient navigators, or in any capacity, support work, or whatever they might be doing. We sit at lots of tables. This is just a small sampling of where NBCC educated advocates are making their voices heard. And we've been, really working with PCORI in the last months quite a bit as well, as they look for educated advocates to sit on their grant review programs. So I just want to briefly tell you that in the way we look at who is an educated consumer and advocate, these are the kind of criteria we look at. So it's an individual who is responsible and accountable to a patient-led, patient-centered organization with a patient constituency. So this is a very carefully crafted criteria, and it sort of distinguishes this group from a lot of other groups out there that call themselves patient advocates. So it's a different definition. This individual is affected by the specific disease or condition in some significant way. And I'll tell you, if the DoD has a criteria that the patient reviewers need to be people who have had breast cancer. That isn't true for other activities or other peer review groups, but for the DoD it is. That they be knowledgeable, trained, and confident in their ability to participate in the decision-making process of science and medicine. They have to be able to stand up and speak up in a room full of scientists where they may be the only advocate. And they need to be a believer in evidence-based healthcare, if not a practitioner, but at least a believer. So we go down this road of really believing in evidence-based medicine and evidence-based healthcare, and it's sometimes a rocky and scary road. And I'm just going to give you a couple of examples of some of the positions that we've taken and how sometimes difficult that might be. And of course, these are the kinds of situations that would then go into the kinds of options that people will get in a shared decision-making clinical situation. So a couple of the just a select few topics that we've been out there with positions on and discussing with these issues in the press, testifying before Congress and before FDA and other kinds of places. The high-dose chemotherapy bone marrow transplant issue, our work on clinical trial for trastuzumab or Herceptin, hormone therapy, and I just want to mention that yesterday, where hormone therapy was mentioned, and there was a little film clip. Yesterday was the 10th anniversary of the results emanating from the Women's Health Initiative, and as I'm sure you all know, that was a situation where we discovered, because there was a lot of push by advocacy groups to figure out what really was the impact of hormone therapy on breast cancer and cardiovascular disease, and the results showed there was actually an increased risk for women who took hormone therapy on breast cancer and cardiovascular disease, and as a result, there was a marked decline. There were over 90 million women taking hormone therapy in the early 2000s, and that dropped dramatically with the release of these findings, and in a couple of years later, we saw the first real decrease in incidence in breast cancer, which has been attributed to the reduction in use of hormone therapy. So ESAs, the mammography guidelines issue, and then this most recent controversy around Avastin, a drug for metastatic breast cancer. So high-dose chemotherapy and bone marrow transplantation was something that really started to become popular in the 90s, and truly there was very little in the way of randomized controlled trial evidence to show that it was a really efficacious therapy. It was for late-stage breast cancer, and it was kind of this combination of all sorts of stakeholders, pushing for this kind of therapy as a kind of last resort therapy. And I just want to read to you quickly from Musa Mayer, who is a really eloquent advocate, and an article that she wrote about this historic case. It took me some time and a lot of study to understand the dynamics of what had happened in America with bone marrow transplants and breast cancer, and how wishful thinking on the parts of patients and oncologists, public pressure, heart-wrenching media stories of desperately ill young mothers, political and legislative mandates for insurance coverage, personal reputations of researchers, and profit margins of hospitals with transplant beds to fill all managed to widely promote a toxic and expensive treatment before there was sufficient evidence of its safety or efficacy. And it took a very long time to also get those results, because people we couldn't accrue for these clinical trials, and then the impact was that this was not a superior to standard of care, and it did bring along with it a lot of harms, and it was, of course, an incredibly expensive and arduous and difficult therapy to go through. So we were pretty alone in our call for evidence before this kind of therapy would be wholesale used, and we worked really hard to accrue for the trials, and then promoted the results when we finally got them. In the case of Avastin, which is a drug for metastatic breast cancer, the FDA gave Avastin accelerated approval based on 2 clinical trials which showed progression-free survival of about 4 months. So it went from 7 months to 11 months of increased life, with many really questionable quality of life kinds of side effects. And it was contingent, this accelerated approval, on the results of 2 confirmatory trials. And when those confirmatory trials came out, neither one of them showed any benefit, very, very little benefit, and even more harms. And so the question was whether FDA would rescind the accelerated approval, which they had never done. And so we were asked to, among others, to testify at the ODAC hearings. And one of our vice president of the organization, who herself has metastatic breast cancer, testified at the ODAC trials. And the reaction was so, by a group of patients, was so extreme. She had to be escorted out of the ODAC trials by security guards. So these are very emotional issues. This is not just a cut and dry story. She had death threats, and we really, this was a really difficult situation. And anecdotes, were really, really very, emotionally charged. And in fact, there may in fact be a subset of women for whom Avastin works, but the company didn't design the trials that way, and so now we have to look at that. So this, I think, was an important case and may set a sort of precedent, and it's very important to understand sort of the ins and outs. So we have lots of consequences of this position that we took, but I think ultimately we gained the respect of FDA and others who could really understand why this evidence-based position was important. And of course, the mammography controversy, I'm sure everybody knows what those issues are about. Screening healthy asymptomatic people. And really over the last 30, 40 years, we have truly oversold the benefits of screening. And now that the results of meta-analyses and systematic reviews have been looked at, we understand a little bit more about the limitations of screening. So when the U.S. Preventive Services Task Force came out with its recommendations, its redefined recommendations in 2009, it was sort of a perfect storm. We were having a conversation about the Affordable Care Act, there were discussions about death panels and rationing, and then this. And so we spent an awful lot of time, because our position had been this position for the last 10 years, talking to the press, talking to women's groups, talking to physician groups and providers, and really trying to kind of put forth the argument about harms and benefits, and what we would have seen had screening really been effective, and that would have been a reduction in distant breast cancers, which we never saw, and we would have seen a larger decline in mortality like we saw in cervical cancer, which we haven't seen. So this was the problem, and the administration, of course, backed down on and did not support the guidelines. So it was a really difficult public health problem. So we need more we need a lot more in the way of good clinical trials to gather really good evidence. We need patient-centered outcomes work. We need to really understand comparative effectiveness research and really educate the community about the issue of understanding risks and benefits. PCORI is trying to do some of that work, and I just wanted to point out some of the questions, the guiding questions that they have identified over this last year that they've been working. And these are, I think, good questions in terms of looking at shared decision-making as well. Given my personal characteristics, conditions, and preferences, what should I expect will happen to me? What are my options, and what are the benefits and harms of those options? What can I do to improve the outcomes that are most important to me? And how can the healthcare system improve my chances of achieving the outcomes I prefer? And I would just add one more, and that is, please explain to me the evidence. So that's our story, and I'm happy to answer any questions.